Hey guys, it's Professor Costa, another lecture. HIV and AIDS-related drugs. All right, so from the Community College of Rhode Island. All right, so what is HIV? It's an RNA retrovirus. And do you guys really need to know that? Some of the medications are related to how this little critter gets into a cell and makes itself a nuisance. So what it is, it's an RNA retrovirus. So it has basically half the equation, and it inserts itself into our cells, which are basically DNA factories. And so it's half the equation. That's what this means. And it needs a something called a reverse transcriptase enzyme to break it up. And you'll see this on some of the next slides, but it is an RNA retrovirus, right? And it needs to be in a living human cell in order to replicate. That's something that all viruses have to do, by the way. Viruses invade a living cell and take over the protein or DNA making factory. And instead of making our own proteins, which we need to live, it turns out little viruses, and and unfortunately that kills the cell. So it's specifically like CD4 T cells, which are an integral part of our immune system. Okay, so unfortunately, when it takes over and it makes, these little baby viruses in our CD4 cells, it causes an immune deficiency. Okay, and when we lose those CD4 cells, that's an indicator of advanced HIV disease. All right, so the CD4 cell count is an indicator for immune function. So that's something that they're going to have counted when they do a viral load and when they do a CBC and things like that. They're going to get their CD4s counted specifically. All right, so this little bugger comes into the cell and he turns, it turns our living human cell into an HIV factory. So instead of the normal proteins that the cell would make for normal cell function, it instead, turns it into a factory or develops all these things. And there's several steps in the process. So it has to, get into the cell, the CD4 cell, and it has to cut itself up, and all these steps. And part of the viral therapies, some of the things that we give patients to combat this little critter, deal with different parts of that HIV life cycle. Okay, so how is this transmitted? It's spread via intimate contact with blood, semen, vaginal fluids, and breast milk. So sexual contact or direct blood. So as a nurse later on, you need to be very, very careful when you deal with blood. And it also can be transmitted between mother and child. Okay, and also via, in utero, which is not as common as we once thought it was, during delivery and through breast milk. Okay, so laboratory testing, something, why would we care in a pharmacology course about this? Well, we need to know, are the medications we're giving our patient, are they doing anything? So yes, we need to know laboratory testing. The CD4 T cell count, all right, or a plasma HIV RNA quantitative assay, or a viral load. So how many little critters are swimming around free, right? HIV resistance testing. So is this bug resistant to what we're currently giving? And additional lab evaluation. So general, the white count is the person showing signs of an active infection. All right. So staging and classification systems. So the U.S. Center for Disease Control and Prevention, the CDC, they stage HIV and AIDS based on very specific criteria. The CD4 cell counts, presence of specific HIV-related conditions. So there are some, really hallmark diseases like Kaposi sarcoma that are, identifiable as someone who has an HIV or AIDS. Okay. So the system is based on the lowest documented. So we drew your labs and we counted them, the CD4 cell count, their nadir, and previously diagnosed HIV-related conditions. There's a chart in your book. You can take a look at that. Okay, so Kaposi sarcoma, There are pneumocystis infections, things like that, that are pretty, like if someone came in and was diagnosed with that, we would definitely make sure and check to see if they had HIV. Okay. The World Health Organization, or the WHO, classifies HIV disease on the basis of clinical manifestations. So that can be recognized by clinicians in diverse settings. So if you're in the jungles of, I don't want to say, if you're somewhere in the middle of the jungle and you have someone who has these clinical manifestations, then chances are then that patient has advanced HIV. All right. So treatment goals, what do we want to do here? This is the whole point of this class, is we're looking at medications, right? So we want to reduce HIV-associated morbidity and mortality. So morbidity is the sick part and mortality is the death. Prolong the duration and quality of life. Isn't that really the goal of any treatment that we give for a patient, be it someone who has asthma versus someone who has diabetes? We want to let them live as long as possible in the best way that they can. And we're doing that more and more with HIV. HIV, I'm not sure of the age. I know there's only a couple of you in my summer class, and if I keep this for future classes, I don't know the demographics. But when I was younger, I'm a little older than some of you probably are. HIV was a death sentence. When someone found out that they had AIDS, it was usually diagnosed at the point when they already had acquired immune deficiency syndrome, were already, almost completely immunocompromised, and it was a death sentence. Nowadays, it's treated in the United States and other developed countries as a chronic disease state, like diabetes, something you live with, take medications for, get your labs drawn, and then you live the rest of your life. That is not the case in undeveloped countries. People still die of this needlessly for the lack of medical care and medications. Okay, but the goal is to prolong the duration and quality of life. Restore and preserve immunologic function. So if we keep this little critter, this little virus at bay as best we can, then the immune function of the individual continues without being impaired. And that's really the goal. All right. Maximally and durably suppress plasma HIV viral load. So we want to keep these guys from we do not want them to replicate in the body. If they replicate, they can invade other CD4 cells, and then we get an immunocompromised patient. So we do not want anything swimming around free. We also want to prevent HIV transmission. So indications for antiretroviral therapy, or ART, right? So who do we give these medications to? HIV infected people, duh, right? We're not going to give this unless there's a high suspicion, or, well, there's a few indicators, but most of the people that get this have HIV, right? HIV infected pregnant patients especially, we want to prevent transmission in utero. Newborns of HIV moms, right? Patients with a history of an AIDS-defining illness. Maybe we're somewhere where we can't get a viral count or confirm the test, but they have something called an AIDS-defining illness in, whatever, end case scenario, where somewhere and they can't be tested, but they have an AIDS-defining illness like Kaposi sarcoma, we may give them antiretroviral therapy. Okay. Patients with HIV-associated nephropathy, hepatitis co-infection, serodiscordant couples. I've had students ask me about this. What the heck is that? Means that you have one person who's tested positive for HIV and the other partner is negative. So, and we want to keep it that way, right? We don't want this to spread. We want to win the battle against HIV. So, in some cases, the other person is given a dose of ART, like a prophylactic dose, to keep them from seroconverting themselves. Okay. Pre-exposure treatment for high-risk populations. So that's kind of controversial, but there are places where sex workers or again, someone who is in a serodiscordant couple may be, treated even though they're not testing positive, to keep them from seroconverting and having a positive HIV test. And then occupational exposure. We'll go over that later. That's the one that a lot of nurses really worry about. All right. So in your book, they break step 2 into, binding and fusion into 2 different steps. I don't really want to worry about that. And I'm not testing you specifically on this slide, but there are people, myself included, when I take a class, I have to know down from the big picture to the little picture, or I can't understand it. So the cell enters the body somehow, some intimate contact. So maybe they had sex, unprotected sex, and now you have someone where we have the virus entering this person's bloodstream. Now what? So it has to bind, and it's called an attachment, and that's where the CCRI antagonist medications work. All right. Then fusion, it's got to not only attach, but now it's got to get in, and we use the fusion inhibitors for that one. Then reverse transcriptase. This has to deal with the fact that it's a retrovirus and so forth. And then we have 2 classes of medications that work at this step. Those are the NNRTIs and the NRTIs. And now it's got to, once it does this, it integration. It's got to get into the actual nucleus, which is the DNA making factory, right? So integrase inhibitors prevent that from happening. Then replication, assembly, and budding. Budding is where the protease inhibitor, so budding means the little long strings of DNA got to be cut up into the right size pieces and budded out. Well, a protease inhibitor prevents that from happening. Again, not testing you on this slide, but I think it's interesting that why people will say, well, why do I have to have 2 or 3 different types of medication? The reason is we want to stop it at multiple points. It's a virus. It is sneaky. It will figure out, well, not figure out, like it's not cognizant, but the DNA will become altered, or the RNA will become altered, and then we get a virus that is immune to this. So if we do it in multiple steps, nip it in the budding part with a protease inhibitor, or prevent it from even binding in the first place with the CCR5, then maybe we can prevent this from spreading. All right, so that's why we use multiple ART agents, right? So they each interrupt a different stage in the HIV life cycle, okay? So these are the ones you have to know for your test, okay? And keep it simple. And yeah, do you notice that a lot of them end with VIR, meaning that they're a viral, or ROC? Okay, those are the big ones that you'll see. So the NRTIs, I am not going to pronounce these. There's one for each stage. There's 2 for the NRTIs and NNRTIs. The first one that I really want you to pay attention to is the zidovudine. If that's the bad pronunciation, I apologize. I deal with that a lot with prenatal patients. So it's preferred for pregnant patients so that they do not transmit that in utero to their baby, okay? Then we have the NNRTI, the efavirenz, the protease inhibitors. You can read this slide, right? The CCRI antagonists are used for resistant HIV. And at the very end, you'll see the entry or fusion inhibitors, and that prevents the HIV from even entering into the cell in the first place. Okay, so the NRTIs, the nucleotide reverse transcriptase inhibitors. Okay, so it blocks the action of reverse transcriptase, which this retrovirus needs to convert RNA to DNA, and therefore then can be copied, right? A lot of these medications upset the stomach, and that's when you can have an issue with compliance. So we tell people, you should take it with food. All right, GI upset, big side effect. So this can cause mitochondrial toxicity and change the body's metabolism. So we're trying to affect with these medications the ability of a human cell's nucleus to use the HIV RNA and make new little baby HIVs. That's what we're trying to do here. And unfortunately, depending on your cell chemistry and your own mitochondrial DNA, we can upset that process, and we can cause things like peripheral neuropathy, myopathy, pancreatitis, and lipoatrophy or fat wasting. And once in a while, you can get renal toxicity. So we're messing with, hopefully, we're messing with the HIV's ability to do this, but sometimes it can really affect our own body's ability to make the needed proteins that the body needs to do its everyday stuff. These are not, unfortunately, these are not specific enough that we're only going to attack the HIV in the CD4 cells. If that, oh, I wish we had medications that did that. We're not at that level yet. So every cell in the body can be affected. That's what I'm trying to say. So the ones that we worry about a lot are in the GI tract, and it can cause a lot of issues there. Okay, NNRTIs, right? The non-nucleoside reverse blah, 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 blah. Okay, so they basically do the same thing. These prevent replication by competing with the binding of the reverse transcriptase inhibitor at the active site. So it doesn't let the HIV do its thing and become DNA, all right? There are a lot of strains that are resistant to this. So sometimes they do resistance testing to see if the virus is resistant to this. So we have efavirenz or Sustiva. This one you don't give in pregnancy, and it can cause central nervous system toxicities, dizziness, sedation, nightmares, and especially in patients with a mental illness or seizure disorder. You are going to see in your practice that a lot of vulnerable populations are who we're talking about here. In the old days, in the 80s, when this disease first came out, it hit people across all lifespans, and yes, the gay population was, targeted with, the stigma, but it crossed all barriers. There were all types of people that were infected with this. Nowadays, okay, if you are a rational adult, most rational adults who are not in a vulnerable population have the teaching and understanding that they know that they have to do things like safe sex, and if they are intravenous drug user, that they should get disposable needles and things like that. They didn't know that in the old days, and so people were unfortunately infected with this. But nowadays, you will see a lot of vulnerable a lot of homeless people come in with HIV. A lot of people with a mental illness come in with HIV. All right, people who are forced into the sex trade. So for this medication, you want to avoid, that it can cause some serious nightmares. All right, this one's taken on an empty stomach, though. All right, and you want to avoid alcohol use and liver disease because it is metabolized in the liver. All right. A protease inhibitor. These are some of the earlier ones. They act at the end of the HIV life cycle. So what happens is the HIV inserts itself. It tells our nucleus to start making long strings of the HIV RNA. And then what has to happen, it has to be snipped into, I like to think of bite-sized little pieces of HIV, but it has to be snipped into the actual viron, right? And you need the protease inhibitor to do that. Okay, so this one can cause GI upset, metabolic abnormalities, right? This one can affect cholesterol and triglycerides and insulin resistance, all right? I hate these names. The atazanavir. Oh, luckily, this isn't a pronunciation exam, so just make sure you know what it looks like. And this one can give you a rash, nausea, and a cough. It's metabolized in the liver, so we want to avoid in liver disease. So this one's hard. The ones that I'm talking about with avoiding liver disease, there are a lot of patients who have co-infections. So they may have HIV and hepatitis. Those are the people that I'm talking about. You really have to avoid using this with someone who has active hepatitis as well. A prolonged PR interval. So when in 2040, when we look at our EKG rhythms, so the actual electrical impulse, the PR interval, this can prolong that, and that can cause a block. All right, so we can have a heart block or bradycardia. Hemophilia. All right. And like most of the other medications in this lecture, you're going to make sure that you take this with food. All right. And then entry or fusion inhibitors, these are the ones that the actual like getting through the cell membrane. So we have the Fusion or the enfuvirtide. It's the only medication in this class. All right, so it actually helps prevent this. To get into the cell is kind of a complicated process, right? It's attracted to CD4 cells, so that's the first step, and then it has to get into the cell through the cell membrane, and the cell membrane's kind of it's like the guy at the bar that lets you in. So this gets around that. What this does is it prevents it from fusing through the cell membrane and getting into the cell. Okay. It's not one that I've given myself. You'll see the table in your book, though. This is listed in the textbook, either version, as one of the exemplar medications. All right. The CCR, every time I see this one, I want to say CCRI, but the CCR5 antagonist, and that's the Maraviroc. Okay. Again, there's only one in this class that we're looking at. I think this is the only one in the class. And the side effects for this can cause upper respiratory infections, cough, pyrexia, which is a fever, and it can also cause hepatotoxicity. So again, those patients with liver disease, alcoholics, or someone who has hepatitis, they'd have to use this with extreme caution. All right. And then the integrase inhibitors. That's the Raltegravir. Sorry. This, again, prevents insertion of HIV DNA into human DNA, limiting replication. More GI side effects. So nausea, diarrhea, can also cause fever and headache. Okay, so what are we going to do? We're nurses. Is a nurse going to sit down and decide, unless they're an advanced practice nurse in a very specialized role, a regular, nurse, one, in the everyday, when you're taking a patient, not everybody tells you every disease that they have. I've had patients not tell me that they have HIV, and then I'm going through their medication reconciliation, and I'm like, oh, they're on 3 different HIV meds. So then prompts the conversation, do you have HIV? Oh yeah, oh I'm sorry, I forgot to mention it. And they, and maybe it's, a legitimate omission, but you should recognize what these medications are, 1. 2, our big issue is regimen adherence. So there are people, I've read off all the side effects. If you had, until HIV makes you sick, it's an invisible disease. People don't know they have it just walking around unless you do, a blood test. Until the immune system is so compromised that they start getting infections. Until then, people appear completely healthy, walking around, doing everything that they normally do. And when you have an invisible disease like that, it's very easy to not want to be compliant with medications that make you nauseated and give you a headache and give you a fever and make you feel horrible. So that's why we have issues with non-adherence. Okay, so what happens is these little critters become, resistant, and we get viral replication. So the more viruses swimming around, the more CD4 cells that are going to eventually become, decommissioned, and eventually this person will be immunocompromised. Also, it increases the likelihood of this person, the more viruses in their blood that are swimming around free, the more likely that this person could transmit to somebody else. Okay. So, promote adherence. We need to make sure that they understand that just taking one of their medications in a combination is not the right thing to do. They have to take all the medications prescribed when they're given on a schedule. All right. And then if there's any food and fluid restrictions, you have to go over that. Recommended food choices. Making sure that they eat, for most of these medications, they eat, before they take this. the right storage, appropriate recording, an appropriate recording sheet. If you have a complicated medication schedule, and a lot of these are a lot easier to take. In the old days, even 15 years ago, they would have to take multiple medications throughout the day at very specific times. They're getting better at making, designing medications that only need to be taken once or twice a day. Okay, but still a recording sheet. When you took it, did you skip a dose, right? And then a contact person. Who to call? I have a question. I have a weird rash. Is it an effect of my medication, or did I get something that I need to have checked out? Okay, so antiretroviral drug therapy in pregnancy. Okay, so the goal is to prevent mother-to-child transmission. All right, so the patient can transmit the virus during pregnancy, labor, delivery, and through breastfeeding. All right, so we want to prevent that from happening. So the lower mom's viral load is, the better off we're going to be, right? The less chance of her accidentally transmitting this during childbirth and during her pregnancy. Okay, occupational exposure, and yes, this does happen. Okay, I had to go through this a long time ago, and it was scary, and I'm glad I don't have to do it now. But that's the world we live in, and when you work around patients and blood, sometimes these things happen. So a needle stick or an accidental splash. Mine dealt with a patient a long time ago with a very, very, very high viral load, and he scratched my arm and drew blood. And anyway, post-exposure prophylaxis, or PEP. So it's initiated within hours of the event, and it's continued for 4 weeks. And they have different recommendations, different combinations. Just know that you're going to take it for a month. So we're going to have the same adverse reaction, 17 to 47%. It makes you sick to your stomach, okay? And the most common reactions are nausea, malaise, and fatigue. It makes you feel like crap, okay? I'm not going to lie about it. And that's just to prevent an accidental, if a viron did get in, from doing anything and causing a problem in the first place, okay? I think that's all I want to talk about on this. There's some great tables in your book. Make sure you really understand patient teaching, recognize what each drug in each class is, and a rough idea of what it does.